So moving along, now another form of obstruction is our friend the prostate. As I start to get older, when I was early on in my career and I see all these patients complaining of getting up at night, going more frequently, slow stream, I'm like, oh, that'll never happen to me. Careful what you think you're not going to get. So anyway, prostate nice and open, but as the prostate starts to enlarge, we can see those lobes coming together, and then here we can see it's so tight that it's actually causing some retention of urine. And it's a progressive disease. It happens over time, so it's not always as noticeable. It affects about 5.6 million men, and mostly it's a degree of bother. Symptoms that patients come in, they're complaining because they just know it's not right. They're getting up in the middle of the night, causes a certain amount of worry and angst. The prostate growth occurs in many patients, not all patients. We do a lot of prostate biopsies and I do the ultrasound, so I kind of measure a lot of prostates, and I've seen 80-year-old guys with 30 cc prostates and 60-year-old with 100 cc, so it's variable. The average growth of a prostate is about 1.6% per year. And don't try to scribble all these down, you'll get the handouts on the website. The average growth increases with age. That makes sense, so it's an older man's disease. Hard to believe, I'm saying older man and I'm in that category. I just turned 58 and my daughter goes, wow, you're almost 60. I'm thinking, yeah, that is an old man. Oh well. Among 50-year-old men, an estimated 35% lifetime incidence of surgical or medical intervention is going to be necessary because you happen to be lucky enough to have a prostate. At age 60, if you're going to live another 20 years to 80, you stand a chance of about 23% that you're going to go into urinary retention. And those of us that have treated it know that's no fun. And nearly 1 out of 10 men in their 70s, if they live another 5 years, are going to end up in the same problem with urinary retention. So it's going to happen to most of us, men. LUTS stands for your lower urinary tract symptoms, and that's what we look at when we're evaluating BPH. The symptoms that we see are that weak stream, prolonged micturition. They're the guys that are in the bathroom and you're like, okay, anytime. They're straining, sometimes they have to, pushing, forcing. They do a lot of Valsalva to void, and that's not an efficient way to get urine out. You can't get the right pressures by pushing with your stomach, and we'll see things like hernias and things like that occurring because of that. Hesitancy, that stream starts and stops, and intermittent stream. And a lot of the complaints that we'll hear is, I just don't feel like I empty my bladder. Now that's what the bothersome symptoms are. The problem is there's some serious complications from that, so you can't just ignore it. And urinary retention, when it's acute, is going to be an emergency call on the phone because they are in pain, or most of the time they're going to be seen in an emergency room. Long-standing, sometimes patients don't know they're going into retention because it happens over so much time that the bladder starts to stretch. The muscle, the sensory part of it starts to desensitize, so they don't feel that their bladder is so full. I saw a patient in the office, asked him how he was, how he's urinating. He said, "No, I'm just fine." He said, "I go a few times, nothing. Don't get up at night." Did a post-void residual. Real skinny guy. Did a post-void residual. He had almost a gallon of urine in his bladder, and it was unbelievable. And of course, when I had him laying on the table, he looked pregnant, but standing up, he had his shirt, kind of hanging out. That look I don't like. And anyway, this guy had to have a catheter in. Obviously, his bladder was way overstretched. It wasn't something you could just fix the prostate because now the bladder's the issue. And that's really the dangers. If it's left unchecked, you're going to start causing bladder damage. And things like trabeculations, diverticulums popping out of the bladder are all, signs and symptoms of long-term obstruction. We can see blood in the urine. That tends to be the thing that gets most men into our office. A guy sees a little bit of blood, they're on the phone. Overflow incontinence. So unlike just leaking urine if you cough or sneeze, overflow is what this guy had. He had such a full bladder that it was water over the dam. So when your bladder reaches a certain point, it will spill over. And that's actually what brought him in, is he had a pad and he was complaining that he was leaking a little bit of urine. It's funny. Men don't tolerate incontinence very well. Women, some of you, I shouldn't say all, but they'll put a pad on and say that's just part of getting old. A guy, they're in the office. So the big thing is acute urinary retention. So that means it's not happened over the course of several years, but one day you get up and you just can't take a leak. A lot of times during the winter, during cold season, men start taking, the antihistamines to help clear up that cold. Well, what do we know about it? The antihistamines, they go and they shut that bladder neck, don't they? And when they do, and they can't pee, and they're in pain, and it's really, you can imagine if you ever, drove in the car and you missed your rest area, and you say, I wish I didn't, and you find out the sign says next rest area 50 miles. We've all been there, haven't we? Well, that's what these guys feel like. It's like, oh my gosh, but they don't always, they're not able to get relief. Initial management, catheters. Often with prostates, what kind of problems do we have with catheters? Maybe a little interactive. How about those big prostates you just can't get a catheter in? So what do you use? Coude. So yeah, the Coude catheter can save you. And a lot of times it does, because these guys have big prostates and they're hard to get around. Plus they're in pain, so they're not exactly holding still, they just want relief. Again, refractory urinary retention may result in surgical intervention. So this kind of makes sense. The risk of urinary retention goes up as your prostate size increases. So bigger prostate, the risk of retention. Prostates can kind of grow two ways. They can just get big. You measure the outside diameter of them, and they should be around 20 to 25, and you see these 50, 60, 70 cc prostates. But what happens is when they enlarge inwardly, they cause the obstruction. I like to go to Dunkin' Donuts, I'll admit it, and you ever get those donuts you just can't see the hole through the center of them? That's that enlarged prostate. Now I've ruined donuts for everyone, right? So what's our initial evaluation? So we want to get a history and symptom score. I'll talk about that in a minute. Physical exam, including a digital rectal exam, and neurologic evaluation, because all these things can seem like prostate, but they're not always prostate. A urinalysis, creatinine, because we did talk about the fact that long-term we could have some kidney damage, so creatinine may be the first number you see a rise. PSA, because we also can be concerned about, hey, so I want to make sure you guys are awake. I can't do all the work here. The AUA symptom index, is everybody pretty familiar with that? The AUA came out with this, 15, 20 years ago, and it looks at the voiding patterns for normal people: incomplete emptying, frequency, intermittency, urgency, weak stream. All of our LUTS symptoms are there, and they have this nice little scale here, and you grade it on a scale of 0 to 5. 0 being not having a problem, and 5, I'm terrible. And at the end of the day, when they add up their scores, they come up with a number. And based on this number, if it's 0 to 7, they have mild symptoms. These are the patients that probably don't really need to be concerned about. The 8 to 19, these are the ones that we may want to watch a little more closely, have them coming into the office at least yearly, checking post-voids. And 20 to 35, these are the guys that are pretty miserable, so they're going to probably want some form of therapy for their disease. So it's kind of a nice index. Digital rectal exam, although most of us wish we could avoid it, is a critical component of the initial evaluation. It gives the urologist a sense of prostate size, consistency, symmetry, so you may detect a later forming cancer of the prostate. It may also underestimate the gland size. Now it's interesting, I said I do prostate ultrasounds with the docs for the biopsies, and a lot of the doctors will say, well, I'm going to calibrate my finger, so I think it's 30 cc's, and then I'll do my measurement, and I know you're wrong. Some of them are actually pretty correct though, so the old timers. But it can underestimate. Again, picks up malignancies and evaluates sphincter tone. Remember I said neurologic, that's one of our neurologic pickups. If they have a weak sphincter there, when you do the rectal exam, you may be concerned of some other issues. And DRE, I like that little comic, but there is a serious side to it. There's a campaign now that, real men don't fear the finger, and they're trying to, push that. Men have to, especially African American, because we know the higher risk of prostate cancer in that group, that try to get in, see your urologist, get your PSA, get your finger exam, you'll live. PSA testing, it increases the detection rate for prostate cancer, but it's not specific for prostate cancer alone. this is one of those things that as you get older, you start to compare your golf scores along with your PSA. So you say, oh, you know, I hit a 40 for that last 9 holes, and my PSA is 7.2. What's yours? So we do know it's commonly done. Unfortunately, I think unfortunately, because of all this press about is the PSA really worthwhile test? Should we be doing it? That it's being done less and less. Now, I've been in urology for 30 years, and when I started, there was no such thing as PSA. There was something called acid phosphatase, which takes a long time, you know, usually metastatic before it goes up. One of the things that I noticed is most of the patients diagnosed with prostate cancer were found by finger exam. When you're feeling something with a finger, it tends to be a more aggressive, more advanced cancer. And that's what I saw back then. Most of the patients that I saw were in their later, you know, stages of prostate cancer. These weren't the early ones. Where PSA changed it was a game changer. You start seeing prostate cancer found at the microscopic level. Differential diagnosis for lower urinary tract includes, so we know LUTS can cause can be caused by more than just BPH. Prostate cancer can do this, bladder cancer, urinary tract infections, strictures, and then some of these neurological things that hit the bladder. So we need to be careful to do a full, thorough workup on that.